Good morning, everyone. I'm wondering, I see that we have quite a few participants as part of this really exciting webinar. My name is Shushna. I'm the Deputy Director for Health and Nutrition for the Bill and Melinda Gates Foundation based in Addis, and really excited about this topic, and just wanted to share a few opening remarks as we get started and then pass it off to my esteemed moderator and this great cast of experts on PhD financing. So first of all, I just wanted to say that the Gates Foundation, as maybe some of you are aware, is an active partner in the global dialogue on primary healthcare. And this has been a core focus of our work, particularly in Ethiopia. And I think the power of Ethiopia's PHC system and the experience that it has had, particularly through the health extension platform, has been a model in many ways. And there are a lot of lessons learned, good and bad. And what it can teach the world is something that's really, really relevant, but also what the world can teach to Ethiopia. There's always this bidirectional need. And so within Ethiopia, I think this is where the Institute, or the International Institute for Primary Healthcare, becomes really important. It's critical in terms of serving as that intellectual engine to lead the evidence, teaching, and guidance for a stronger PhD system. And so that's what we're doing here today. And the Gates Foundation very much shares the Institute's externally facing vision of becoming a WHO collaborating partner and serving as a regional African leader in primary healthcare. So we're really excited to support the Institute and these webinar series. I know I've learned a lot after attending many of them. I think while Ethiopia has been celebrated for its health extension program in particular, as well as for having remarkable progress in terms of some key outcomes, I think what hasn't been as public has been Ethiopia's willingness to study challenges and to continually adapt. And that too is a form of leadership. And so this institute really takes that very seriously and is positioned to support the growth and strength of this direction. And so within that realm, I'm excited for the topic of this week's webinar. If PHC is the foundation or bedrock of the health sector, its financing is all the more critical and important to get right. And it's perhaps the most difficult to get right. It's not easy. And this is where we can really benefit from many other country experiences. And for this reason, really excited about this panel session. And so on that note, I want to introduce my colleague, Saran Ellis, who's going to be the moderator for the session. Saran joined the Bill and Melinda Gates Foundation in Ethiopia as a program officer in 2017, trained as a health economist, as well as a public health specialist with extensive country experience in Ethiopia, Zambia, and elsewhere in Africa. She currently supports our primary healthcare systems work, leading our supply chain portfolio, but most recently, most excitingly, especially for me, having also come from a healthcare financing background, she is leading our emerging healthcare financing portfolio. And that's another reason why this panel session is very timely, particularly for us at the Gates Foundation. So with that, I'd like to turn it over to Saran.
Thank you, Shushna, for that very kind introduction. And it's my honor to introduce our panelists for today's discussion. And I will introduce them in the order in which they will be presenting. So starting with Professor Kara Hansen, she's a health systems economist, and she's a dean of the Faculty of Public Health and Policy at the London School of Hygiene and Tropical Medicine. She's worked on a range of settings in sub-Saharan Africa and Asia, starting her first job as an ODI fellow in the Ministry of Health in Eswatini. She's a doctorate from the Harvard School of Public Health and joined the London School in 1997. Her interests include the role of private sector in health systems, identifying the opportunities and limitations of the private sector in improving efficiency, quality, and responsiveness, and novel approaches to regulation, particularly in relation to market disruptions. She's also worked on health financing reforms, particularly the way the strategic purchasing can help improve health system outcomes. And so Professor Kara will walk us through the global evidence or landscape on primary healthcare financing. And after her presentation, Dr. Sudarshan will be speaking with us, and he'll be providing us some of the experiences in India, especially with public-private partnerships. He has over 40 years of experience, and he served in many important roles advancing healthcare and social work in India. And this includes founding and serving as the Honorable Secretary for the Karuna Trust. He's also a member of the advisory group on community action and ASHA mentoring group of the National Rural Health Mission of the Government of India. He's a former vigilance director for the Karnataka Lokayukotha, sorry, I'm botching that completely, so I'll leave that out. But he's a former director and a former chairman for a task force of health and family welfare at the government of Karnataka. His awards include the Padma Shri, which is the highest civilian honors of India, and also the prestigious Right Livelihood Award, which is known as the alternate Nobel Prize. And then after, we will be joined by Ms. Atal Shetty, who has more than 25 years of professional experience in the areas of health system strengthening, health policy, and health sector financing. He's a master's in economics and a postgraduate diploma in development planning techniques. So Shetty is from Ethiopia, and he began his career in the government of Ethiopia and was very instrumental in leading its health financing reform initiatives. He's currently working as a consultant for USAID Madagascar, and this follows an illustrious career in USAID Ethiopia, where he officially retired in 2018. During his tenure there of several years, I think over 12 years, he served as a deputy team leader and a team leader for the Health Systems Strengthening Program and oversaw many health system strengthening projects. He was also a cognizant technical officer for the flagship Integrated Family Health Program while at USAID. He's also worked in USAID Afghanistan during the years of 2014 to 2015, and has worked as a consultant for many development organizations, including the World Bank, FCDO, and CORDAID, conducting project evaluations and assessments, and has received a Lifetime Award from the Ministry of Health in Ethiopia for his many contributions to the advancing health systems and the health financing agenda. And so Shetty will walk us through the Ethiopia experience and with health care reforms. So without any delay, I'd like to turn this over to the Professor Kara, and she'll start, and then we'll continue onwards with the other two presentations. Thank you. Go ahead, Kara.
Thank you very much, Saran. So I'm going to share and, now what are you seeing? Are you seeing the right thing?
Yes.
Okay, fabulous. So it's a huge pleasure to be here today because we have just launched this, this report, which is a Lancet Global Health Commission on financing primary health care. This was launched on the 7th of April, so it's our 5th of April, 5th, 7th, 2 weeks ago. So it's really hot off the press, and I wanted to take this opportunity to share with you some of the findings of our report. So I think I probably don't need to rehearse the challenge with you and the importance of primary health care, but maybe from the financing side to say that the money for primary health care is often insufficient, and that ineffective or inappropriate financing arrangements can lead to a poorly performing service, a lack of financial protection, and inequalities in access to care. I think it's also useful to note that the pandemic has created a health and fiscal crisis that really highlights the dangers that societies face without a well-functioning PHC system that protects everyone. So the objectives of our commission were to present new evidence on the levels and patterns of global expenditure on primary health care, to analyze the key technical and political economy challenges faced in financing PHC, and then to identify areas of proven or promising practice across the health financing functions to support primary health care. And then from that, to identify some actionable policies to support low and middle income countries in raising and allocating and channeling resources to support primary health care. So we really structured our report around these three main financing functions. So we looked at revenue mobilization and pooling. We looked at allocating resources for PHC, and then we looked at PHC provider payment. But we also underpinned this as a thread running through the entire report by the need to understand the political and economic and social context within which decision-making takes place. So I'll just start with a little bit of data. The first is really the very low levels of government spending on PHC in low and lower middle income countries. So you can see that in low income countries, the average government expenditure on PHC is $3 per capita. And this is so far short of any of the benchmarks that we know to be to provide adequate funding for a comprehensive package of primary health care. And this contrasts obviously with the much higher levels in high income countries, but even in lower middle income countries at $16 per capita, it's simply not enough money is being spent on PHC. In low-income countries, the predominant source of funding for PHC is out-of-pocket spending. And that, of course, causes a range of problems, firstly in terms of financial protection, but also in terms of the absence of pooling of those funds. And this is really in contrast to high-income countries where the greater role of government revenue in health, in greater availability of government spending enables more spending from pooled sources for primary health care. Another finding, this comes from a survey that we did of over 70 countries of the arrangements of paying public PHC providers for primary health care, is that capitation, which we argue, as you'll see, is really the very best way to be paying primary healthcare providers, is used very rarely. So in low-income settings, you can see that that light blue, well, there's virtually no capitation only. There's very little blended capitation. I'll explain what we mean by that in a moment. And that input-based budgets were by far the most common way of paying primary healthcare providers. So let me just spend a couple of minutes on our key findings. The first is around the mobilization and pooling of funds for primary healthcare. And here, you can't really separate funding for PHC from funding for the health sector as a whole. So we argue that there's a real need to increase public funding, and that the best way to do this is through taxes, and in particular by improving the collection of existing taxes, by increasing the tax base, and by expanding the number and types of taxes, the taxes that can be levied. And this obviously is not just a technical issue, it's an important political issue because of the role of political interests in setting tax policy. We recognize that efficiency gains are a potential way of releasing fiscal space for health and for primary health care, but I think we also felt that the evidence was that these efficiency gains are much more difficult to realize in practice. And then to ensure that those efficiency gains are actually lead to increased fiscal space, either for health or for PHC, can't be taken as a given. Perhaps one of the most important things we said is that pooling arrangements really must cover PHC. So a number of countries have expanded their kind of UHC coverage schemes, but in some places this covers only tertiary or hospital level care. And we know from the accumulation of evidence that particularly for people with long-term conditions, that the repeated small expenditures attached with PHC can also drive households into poverty. So we would argue that PHC should be covered first in pooling arrangements. The second set of findings are around how to allocate resources to PHC. So again, we'd recognize that allocation questions are fundamentally political, that reallocating and redistributing health budgets often will serve some interests well and will undermine others. And so it's important to recognize the political nature of those decisions. And we argue that there are three sets of policy levers that can be used to increase allocations to PHC. The first is through the budget formulation process. So there are examples of countries that are adopting program budgets for PHC. There's examples of other countries that have quite successfully used budget rules and statutory appropriations to be able to not just channel resources to PHC, but also to encourage in federal systems to encourage state level contributions to PHC to increase as well, or another set of tools around conditional grants. There's an important set of budget execution tools. This can include the use of resource allocation formula, the use actually of provider payment as a way of directing resources to PHC, the use of contracting arrangements, and then other types of measures such as direct facility funding. And finally, and this I think is really interesting in relation to Ethiopia, is that some countries have changed their service delivery arrangements in order to find a way to pull resources to PHC rather than pushing them. That requires an operational definition of PHC, the setting of some norms and standards, and then some quite careful attention to the referral system and gatekeeping in order for resources not to get pulled back into hospital care. And then these novel service delivery models, whether that's through community health workers or through family doctors, but those can be an important force in attracting funds to PHC. Our third set of recommendations, or a set of observations, are really around provider payment. So the way that PHC providers are paid and the incentives that are used in these payment mechanisms are a crucial tool to make sure that resources reach frontline providers and that they're used efficiently. And we argue that some form of population-based payment or a capitation payment creates the strongest incentives for providers to deliver people-centered PHC. So this involves an equal payment per person that can be adjusted eventually based on health needs, that you then pay providers to manage population health and to prioritize health promotion and prevention, and that this type of capitation or population-based payment provides a stable and predictable income stream for PHC providers. And so this picture here that I'm showing you is our proposal for a pathway to more strategic provider payment that recognizes that this needs to change from a passive to a more strategic purchasing orientation, and it needs to align incentives, and that there are some steps then that can be taken to move along this strategic pathway towards a more blended payment system. We say blended payment system because all health economists know that any provider payment mechanism has some perverse incentives as well as some good ones. And so it's important alongside capitation, which can have an incentive to under-provide care, it's important that that's accompanied by other measures to encourage certain types of high priority care or to encourage performance. The last piece of our puzzle was around political economy. And here we really wanted to convey that the political and social and economic conditions of a country are as important as the technical elements in the design and the implementation of equitable and efficient financing for PHC. And that and bringing these two together means having a politically informed technical strategy. It also requires having a long-term vision that helps to kind of drive a constant focus on PHC and on PHC financing. And that sequencing is important. So these political moments where it's possible to make change need to be supported by some preliminary work, some existing work and thinking on having sound technical strategies that then can be drawn on when there's the right political moment to change. So our recommendations are four. One is we recommend that people-centered financing arrangements for PHC should have these attributes. It should involve increasing allocations to PHC from tax revenue, that pooling arrangements should cover PHC, that resources should be allocated equitably and protected so that they really reach those frontline providers and they're able to meet the needs of patients. And that the provider payment system should have capitation at its core, blended with other mechanisms to encourage providers to focus on priority activities. The second is that this really requires a whole of government approach. Clearly, ministries of health need to work with ministries of finance, but also a range of other ministries in order to encourage spending more and spending better on primary health care. The third is that technical strategies should be underpinned by a careful analysis and understanding of the social and economic and political conditions in a particular setting. And finally, we had a very specific recommendation around how PHC data are collected and classified and reported, and some recommendations to the global level institutions that govern the collection and reporting of health expenditure data. So I'll stop there. I would really encourage you to visit our webpage, but also the Lancet Global Health microsite on the Commission's report that also contains a series of commentaries from others on the report and some technical briefs for a quick look at this. Thank you very much.
Thank you, Kara. If I'll just, for the sake of time also, just turn it over to Dr. Sudarshan. Please go ahead.
Yeah. Thank you for giving me this opportunity to share my experience in primary healthcare in India. Next slide, please. Next slide, yeah. So in India, we have PET scans, MRIs, we do heart transplants, but we have very few functional laboratories in remote primary health centers. And people do not get treated even for WCOM anemia. These are the two Indias. So health services for the scheduled caste and scheduled tribes is very poor, and out-of-pocket expenditure for the poor is 60%, which is spent on drugs and diagnostics. Next. Now, overall health financing in India, it used to be 0.9% of GDP. It has gone up to 1.6 in the last 10 years. But we were part of the Commission on Macroeconomics and Health, and at that time, the Prime Minister had promised that it will increase to 2 to 3%, but we are yet to see that. The public versus private spending is 1:3. I think that needs to be reversed. In a country like India, I think public spending has to be more. Primary healthcare spending is less than 30% of the total health budget. The recommendation is in the universal health coverage, we had a task force where we said 70% of the should be for the primary health care and 30% for secondary and tertiary care. Next. Now, I basically will be talking about public-private partnership as role in the primary health care. Just want to clarify this public-private partnership because many of our leftist partners will declare it as privatization. I am not for privatization of healthcare. It is partnering, and it is public financing of the public-private partnership. Next, please. Now, private sector in India plays an important role. 80% of the outpatient care is by the private sector, 50% of inpatient care is, and 95% of the preventive, promotive, and the primary health care is by the public sector. This is very important. Private sector is not much involved in the primary health care. When I say primary health care, it's not primary clinical care, but comprehensive primary health care. We also have informal providers. Quality of healthcare is also a problem, but it's much better in some of the private and public sector hospitals. Next. Now, for public-private partnership, I was also involved in this in secondary and tertiary care through a health insurance. We call it health assurance program. I'm the founder trustee in Karnataka state. We cover now universal health coverage for below poverty line, above poverty line. So all the other people are also involved. We have a universal coverage now. And this has been merged with the recent Government of India Ayushman Bharat. So we have a good protection for the secondary and tertiary care. Next. Now, in primary healthcare, as of today in India, it is mostly by the public sector. And we wanted to partner with the government and manage. Earlier, as an NGO, I was doing parallel duplicating work in primary healthcare. Then we said, we discussed with the government. So government decided to hand over the primary health centers, which are remote, inaccessible in conflict areas, which they cannot manage. We took up those challenges and formed this public-private partnership in managing this. I was also involved in as a task force, also recommended this public-private partnership for primary healthcare. Next, please. Now, I want to define my concept of primary healthcare because there is a lot of confusion about definition of primary healthcare itself. So when we say comprehensive primary healthcare, India is committed to All-Matter Declaration. We believe in community-based preventive, promotive, curative, rehabilitative, palliatives, all 4 components of services, which includes mother and child health services, communicable and non-communicable diseases, and specific local problems, addressing all the other determinants of health like safe water, sanitation, and nutrition. Now, in the primary health care centers are called health and wellness centers in India. Next. This is my favorite diagram to again re-emphasize the preventive, curative, promotive, and all 4 components are important: community participation, appropriate technology, multi-sectoral approach, and equitable distribution. Next. Next, please. This is usually in India, a primary health center will cater to a population in rural and tribal areas, 20 to 40,000 population. We have a primary health center. Then there are sub-health centers for every 5,000 population, 2 to 3 villages. And then usually have a 6-bedded indoor facility, outdoor facility, and many ASHAs at the village level. ASHA is a community health volunteer. And then we have sub-center auxiliary nurse, midwives, and male health workers. And medical officer is at the PHC level, primary health center level. Next. So we have shown that we took up one of the Gumbali PHC in 1996. I'm very proud to say that in 1 year we attained 0 infant mortality. Difficult to maintain that status, but we have drastically brought it down. Next. The MMR has also considerably reduced. Next. Next, please. We have made several innovations within the limited budget, which I will be talking about. I call them process innovations and also ICT innovations in telemedicine, many other things. Next. We also community-based mental health program in all our PSCs, the vision centers, NCD screening, including cancer, oral, breast, and cervical screening, dental health care also as part of the primary health care. But most important is community, involving the community in planning, action, and monitoring of the services provided to them. Next. This is a PSC bombing in northeastern India, very difficult area. There is no telephone connectivity, no electricity. I went there, we took over the wild boars running around the PHC when they handed it over. Now it's fully functional. Next. This is a Waka PHC where insurgency is a serious problem, again in the northeast in Arunachal Pradesh. Next. These are very difficult terrain in the northeast. We have to pass through the Brahmaputra River. Next. We use elephants to cross the river during the rainy season. They are health workers. Yeah. Next. Sometimes our health workers have to use these type of bridges to reach what I call reaching the unreached in primary health care. Next. This is a symbol. This village is cut off during the rainy season. There is a roadway built by the army. Our health worker is using that to go for the immunization of the children in those villages. Next. We also have sustainable energy in our health centers. Next. We have solar vaccine refrigerators. Next. We have solar powered non-communicable disease screening unit. Next. So we cover the northeastern India, the Karnataka, Orissa, and several remote places. Next. So at present, we cover 71 primary health centers, cover 1.5 million population. Next. Under public-private partnership. We are the first to get accredited by the National Accreditation Board I initiated the process for accrediting even primary health centers. For primary health care, we are proud to get this certificate. Next. We also have a primary health care fellowship program as part of the Karna Trust and the Association of Family Physicians of India. Next. So the cost benefit, the PPP, the government agreed for PPP saying they will give only 75% of what they are spending, not capitation fees. And then they increased it to 90%, but they don't give the supervision monitoring costs and several other costs are not there. So at present, why $3 per person per year? That's the budget government gives. So we took up that challenge and showed that with $3 also, we can provide all these services. So spend less than the government with better health outcomes. Next. Next, please. Now, financial resources for primary healthcare in Karnataka through the state governments and the public-private partnership. We have health insurance also, a corporate social responsibility funding. We are also cross-subsidizing, charging the rich and making it free for the poor. Next. Now, we also tried a community health insurance model with the WHO and Government of India. But we successfully ran it with women's self-help groups. But I find I'm very committed that primary healthcare, this is also policy of the Government of India that we cannot have user fees for primary healthcare. So we don't charge for the primary healthcare, and it has to be either through donors or some way. But I think it is not appropriate to collect money, raise resources from the user fee. And we have enough studies. I find that Ethiopia is doing it, but I think enough studies to show that user fee has done more harm than good for the poor. Next. We also partner with the CSR funding. Next. I was also chairman of the Task Force on Health and Family Welfare, and we identified 12 major issues of concern in primary healthcare: the corruption, neglect of public health. I will not go into all those details, but definitely primary healthcare was very important. Next. Human resources. Next slide, please. So, as you see, corruption has been put on the top of the list. This was based on evidence. So our health secretary was very upset in a government report. How can you talk about corruption as a major issue? I did change it and I insisted on that. Later on, I became an ombudsman in Karnataka. It's an ombudsman organization to control corruption. And I served in that as an ombudsman for 4 years and made several transparency, accountability mechanisms. So what I want to say basically is we have in financing healthcare, I am for increasing the budget from $3 in India to, I've made recommendations for at least $20. But what is most important for India and Ethiopia is the leaking vessel. You put more money, even if you put $20, it won't help in the outcomes. So first we have to plug the loopholes. The good governance is very important. So if we have good governance and then have a comprehensive primary healthcare, we'll have quantum jump in health outcomes. So that's my contribution. I think in all developing countries, corruption is a major issue. We are shy of talking about it. I think we should accept that and then have community monitoring by the community where the service provider is monitored by them. They openly talk in their village health and sanitation committees how much bribe they have to pay in the hospitals, for services. All that is openly discussed. So people are now cautious. Definitely, the out-of-pocket expenditure has come down in the primary healthcare. So I think while monitoring the effectiveness of primary healthcare, the most important indicator is also whether we are reducing the out-of-pocket expenditure for primary healthcare. Thank you.
Thank you so much. I just want to make one quick comment. If you have any questions on what you've seen so far, could you please use the Q&A tab for your questions? It's a bit easier to follow and make sure questions are responded to from there. Thanks, Dr. Sudarshan. I will now ask Ato Ishete if he can give us the Ethiopia experience. Thanks.
Thank you so much. I will just directly go into the presentation. Next slide, please. Yeah, this slide shows, the movement of the Ethiopian healthcare financing reform during the last 25 years. Next slide, please. Ethiopia's journey of reform in healthcare financing started in 1998. When the health financing strategy was approved by the parliament, and that is with huge implication in policy changes. The reform includes a retention of fees collected at the facility level and utilization. And then the next phase, the next generation is pooling of resources. The good thing about this process in Ethiopia, the reform is, it is government-led. It is sector-wide. The health sector development program of Ethiopia included as one of its major component and priority health sector financing reform. It's very much participatory. Of course, the donors are also supporting this activity. Next slide, please. User fees was there for years before the healthcare financing reform. New reform, however, changed the fee structure, its use, and put in place consistent policies and guidelines on the use of the fees retained at the facilities. Prior to the reform, facilities collect user fees, but they are sent to the treasury, to the central government of Ethiopia. But while all health centers, which are the core for primary health care, are shortly suffer from operational budgets. And then the facilities, the health centers, the hospitals, they are not motivated to collect and reduce wastages because of their collection levels do not directly affect their performance, their operation. Next slide, please. Then this is the most important thing, then the reform implemented decentralized facility governance bodies by law, by proclamation, allowing facility governance body to manage the resources generated at the health center and hospital levels, and the use for the priority of the data specific area. Yes, please. Next slide. Yeah, thank you. And then the goal of this, please go back. Yeah. The goal of this governance reform was for health facilities, including primary health care facilities, to use and have this entitlement, responsibility, authority to use for their priorities. And this has got a huge implication in addressing allocative efficiency, targeting primary health care, and managing service delivery. And then all the resources retained at that facility is managed by the hospital managing boards or the health center managing team. Next slide. And this, the most important thing here to understand is the resources, the fees collected at the facility and which are used there are additive by proclamation, additive to the government subsidy. You can understand the implication of that. And they are used for ensuring the availability of essential drugs, which was a serious problem in Ethiopian context. You can imagine we are talking about more than 3,000 and more than 300 hospitals in the country. And they are used for the availing essential drugs and improving maintenance, utilities, and you name it. And then there are some studies which show that 41% of the amount of the fees collected at a given health center or hospital is almost like 41% significant. It's very much significant. In addition to that, in some hospitals, private wings are also instituted to get additional resources and also to create incentives for specialists to address the attrition, the high attrition rate that's happening in the country. Next slide, please. Now, you can see that the coverage, this is very much nationwide program reform, and many of the health centers and many of the hospitals are using have functional boards, and the RRU is revenue retention and the use is being implemented based on the guidelines, the principle outlined there. Of course, there are variations. We have got the lowland in the lowland Afar, the lowland areas like Afar and Somalia. The implementation is very much slow, but still there is an effort to implement the reform. Next slide, please. And then the most important thing before we go into the challenges here, What are we learning from this reform, which is the supply side? This part is that it is decentralization, focus on decentralization. It addresses allocative efficiency, focusing on the primary health care, making available resources where it is needed, and also, it is liberalizing the public sector delivery system. When we say liberalizing, it means that retention and owning, allowing, creating decision space, increasing decision space at the lower level is elements of liberalization. Outsourcing, all these are elements of liberalization. These are the messages from what we have. It has worked very well. And then there are challenges here and there. In some places, revenues are not fully utilized. In some places, limited audits and skills of financial management. And in some places, non-functional facilities are observed. And then the other challenge, which hinders the quality of services, is, of course, it is a supply system, the national drug supply system. Next slide, please. Now we are moving to the other aspect of the reform. In some cases, in terms of community-based health insurance, we call it the next generation of the reform, the second generation. The risk protection mechanisms include, I think it's very slow. Can you see the slides? I don't see them. Yeah, please. The exempted programs, the primary health care, particularly the health extension program, the services at health posts are free. The programs, they are free there. The family planning, the infectious diseases, all these behavioral change activities are free. That's the most important thing in Ethiopia, reaching underserved population across the country. Next slide, please. And then the exempted programs are very much obvious. These are mainly depend on foreign aid, particularly for the commodities. It is a challenge as we go along in the future, but these are all activities, all programs at this level are very, very free for everybody, available for everybody at all facilities, particularly at the primary health care level. Fee waiver. Exempted programs are different from fee waivers. Here in our, the word we use as a waiver is targeted poor people. And then this is a challenge, targeting, identifying the poor and financing, putting aside resources to pay for the poor is a challenge. But as community-based insurance moves, I think there is very encouraging result there. And now, next slide, please. This is a huge undertaking in Ethiopia. Ethiopia is very much engaged in community-based health insurance, learning from other countries like Rwanda and others. I think serious attention has been given. And then earlier on, I think we understand that fees are not really advisable. Fees are, or cash and carry systems are not advisable. We are very much, Ethiopia is very much aware of that. That's why we engage heavily on community-based health insurance in Ethiopia. And then for us, why are we talking about community-based health insurance? Because the large population of Ethiopia lives as agrarian farmers, and therefore we have to focus on the informal sector. Of course, social health insurance is not forgotten. There are some movements on the informal, but it is very limited coverage. Therefore, community-based insurance is the most critical element for primary health care, reaching the unreached rural population of Ethiopia and protecting them from catastrophic health expenditure. And then it is by way of doing that, it is increasing service utilization in the country, particularly in the rural area of Ethiopia, and ensure also equity to the extent it is possible. Next slide, please. Now, it is also, again, this undertaking is also a national program. I can say that community-based insurance has mushroomed in Ethiopia everywhere. Of course, with the performance of the regions vary from place to place, but now we can say that the routine information report shows that we are reaching more than 40 million beneficiaries through the health insurance, community-based health insurance. And then I think that there is very interesting result that also the point, something like very close to 8 million beneficiaries are being paid, subsidized by the government for their premium. In the pastoralist areas, there are some schemes, but there are a lot of issues to be considered in that, in the lowland areas. You can see that it's not only the protection mechanism advantage that it provides. CBHI is another tool to increase domestic resources in the country. And then what we learned from the community-based insurance in Ethiopia is that what we learned, the most important thing is that community-based insurance works when it is taken to scale, meaningful scale up, coverage for the obvious reason of economics of scale. And also when it is supported both from top down and bottom up. That worked very well, as it is the case in Rwanda, also in Ethiopia. And then the service utilization in those areas where the CBHI is being implemented has increased. And you can see some equities being insured. And also the most interesting part also again is it enhances women empowerment, because the women should not ask or request their husband to get health services because their premium is already paid and covered. And the community participation engagement has increased significantly. Next slide, please. This is just to show, this presentation is not data intensive, but the Ethiopia started national health account years back, and now we have done, the third, the eighth one. It's very interesting, and then it is institutionalized. This huge achievement, national health account is very important. It tells us the figures will speak by themselves, who is financing, where the resource goes, and it is very important now. We are at the level of something like a capital health expenditure for Ethiopia is at 4.40. It's the most important thing is happening as always. Next slide, please. And then overall challenges. This is implementation challenges, very much obvious. A security issue, COVID, staff turnout, and all these things are very obvious reasons. But they are not included. I have got some recommendation for Ethiopian healthcare financing in a broader sense, bigger picture. I think the most important thing is to keep the momentum, and the recommendations implies challenges. In the recommendation which I'm going to mention, challenges are embedded into them. Ensuring the continuity of the reform and dealing with the new emerging issues are very important. And improving the supply system, the community supply system, which is hindering the performance of healthcare financing, particularly CBHI, is extremely important. Wherever it is needed, also focusing on the catch-up interventions, particularly in areas where the conflict has affected the performance. I think this is very important. And always, there are some issues forgotten in Ethiopia, community-based health insurance areas, accreditation. Accreditation is very important of health facilities to ensure the quality of services. And also considering the engagement of the private providers in insurance schemes is very important. I know the tariff issue is there, but there must be some kind of consideration to engage them to ensure the quality of health services. And then one very important element which we need to consider in Ethiopia is considering the context. Ethiopia, there is agrarian Ethiopia, we have got urban Ethiopia, we have got pastoralist Ethiopia, and unfortunately now also we have got war-affected Ethiopia. And therefore, all interventions and all reforms, all interventions should consider all this context, and service delivery modality should consider all these aspects. And another very important element particularly for community-based health insurance is to consider the next, pulling to the next level, the zone, the region, and so on. And this is very important, and in that implies a huge engagement in improving the governance system. And another very important very important area to consider for the Ministry of Health of Ethiopia is creating synergy among different reforms: health information system, the supply system, healthcare financing, insurance. Oh, these are very important. That synergy is very important. Next slide. Thank you so much. Over.
Thank you, Ashete. Well, there are a few questions, and I think what we'll try to do is to start with a general question, which we'll ask Professor Kara to respond, and then others to comment. So the question is, what is the effectiveness of performance-based financing mechanism for community health workers? What are the recommended interventions?
There we go. That's a really good question. So there is some evidence of using performance-based financing for community health workers. I suppose in general, my feeling is that performance-based financing should not be a core financing mechanism. It should be something that complements or supplements something else. So if there's particular interventions that you want a focus on for a period of time, then a performance-based payment can be a really powerful way of kind of turbocharging that intervention. But the providers get used to the incentives and they adapt and adjust, and so it shouldn't be the core way of paying health workers over a very long period of time. And I think that probably applies to community health workers as well. So we do talk briefly in our report about the need to consider carefully how to pay community health workers, whether volunteerism can be sustained indefinitely, what are the benefits in terms of integrating them into the health system. So I think it's a powerful intervention around the edges, but it shouldn't be the key way of paying any providers within the system. In terms of specific interventions, I think that comes down to kind of local decisions about what the core package of interventions should be for different levels of primary health care. So we didn't really get into the choice of the package in our own report.
Thank you, Kara. Anyone else would like to comment before we move on? I think I'd like to try to get, there are a few questions, but at least one for each person, and then we can try to tackle some of the questions. Any other insights from our panel?
About the performance-based, in India, we have community health workers called ASHAs. So we have performance-based payment only for ASHA workers, but the doctors, from the minister to secretary, nobody does the performance appraisal. So if you are doing it, why only for health workers? Do it for everybody. But victimizing only the health workers, and now the Indian strategy is to have a fixed base and then additional incentives, as Professor Kara said, right? Thank you.
Yes, if I can I add one point here?
Yes,
Performance
please.
financing is a very tricky and a controversial approach, but it works if it is properly designed and also not financed by development partners. If it is financed by domestic resources and properly designed, may be complemented with some grants. I have seen in some places working very well. And then it requires a very well-organized governance structure where the checks and balances are put in place. Thank you.
And just a reminder that we do have the Q&A tab that you can put questions in. Some of the questions that have been asked have already been answered. Thank you very much, Kara. So I will now try to read one of the questions that's specific to Dr. Sudarshan. It's in the Q&A, so I'm just going to read it, at least, sorry, try to summarize it. So Dr. Sudarshan, this question is for you. You've outlined the challenges and success stories in regard to PHC in India. One of the personal challenges this person has faced in working in government urban centers was a lack of focus on provision of comprehensive primary health care. The focus was more subcontracting to private hospitals and reimbursing them for fee-for-service basis. Despite willingness to provide comprehensive primary care, we couldn't do so because of high focus and impaneled hospital and poor governance. It's more a comment, but I just wanted to know if you had any response to that insight or feedback. Thanks.
Oh yeah, well, if I rightly understood, it's about urban primary healthcare. So the urban primary healthcare is still in primitive stages in India, very poorly planned. We try to imitate the rural and tribal primary healthcare into urban primary healthcare. The infrastructure is not adequate. These are mostly in the slum, urban poor areas. I think we have a long way to go, but a good beginning has been made, but not adequate. I totally agree that the urban primary healthcare centers are yet to take up comprehensive primary healthcare, but we are moving towards it. Thank you.
Thank you. So now I'll go to a question I see here for Ashete. And so there's actually two. Let me see if I can very quickly go through this. It says some of the curative services are provided at health post level. So what type of financing mechanism do you recommend? What implementation modality do you recommend, and what possible changes? And then there's a question about the pooling of CBHI schemes. You mentioned this in your presentation. What is the possibility of pooling CBHI schemes to zonal, regional, and national levels?
Yeah, thank you so much. I think all the services, particularly at the health post level, the health extension program, yeah, the health post levels are free. There are some curative activities, limited, and all those are also, particularly for child health illnesses, they are all free. And then one thing which I don't know where it stands now, needs to consider is linking in terms of financing the health posts as a satellite entities into the health centers. And this is coming, and so that they get the health posts, they don't have finance, they don't have resources to get some resources from the health center. This is the idea. Then pooling the resources zone should happen. It's very important to do that. I think in Amhara region, it is happening in one or two zones. I don't know where that stands. It is happening and it's moving. It should be there. The pooling is very important for reinsurance of the schemes. I thank you.
Thank you, Ashete. So, Kara, I have a question for you. How best can PHC be presented as a political movement to attract the much needed attention towards it?
Yeah, no, that's such a great question. I thought it was really interesting that the question comes from a colleague in Zimbabwe who noted that early after in the immediate post-independence period that PHC was presented as a political movement and was able to garner that support. And there's lots of forces that undermine that. The fact that hospitals are more visible, that they tend to be used by urban elites, that they tend to also, so somebody else asked a question in the Q&A about career pathways, and that somehow sort of being hospital doctors carries more prestige and more recognition than PHC workers. There's lots of reasons why it's hard to make the political case for PHC, but I think we just really have to keep pointing out that it is the foundation of all successful health systems. We know there's evidence that the countries that responded best to COVID were countries that had strong PHC systems. The countries that are able to address health inequalities better are able to do that through their strong PHC systems. And that also that as chronic conditions become a bigger source of disease burden, that really can only be managed effectively and cost effectively at the PHC level. So I think it's up to us as kind of technical experts to make the case to politicians as to why an effective PHC system can be a vote winner, why it can attract popular support. But it is a challenge, and I think recognizing some of the forces working against it is quite important as well.
Thank you. I think seems to be quite a lot of interest in understanding more about the CBHI journey in Ethiopia. So, Shete, there's a question here on it says good progress in CBHI. In some contexts, the effectiveness of CBHI is constrained by limited pools, which undermine risk subsidization and financial protection. So perhaps you can describe a bit more on the strategies Ethiopia employed to overcome these barriers. I know you mentioned some of the challenges that you're facing, but if you could perhaps provide a bit more specifics on that. And then also how do you see efforts of the government to make sure that vulnerable segments of the population are included in the CBHI, including NCD patients who don't follow their treatment due to financial constraints?
This is very, very interesting issue. There are many, many other emerging issues as Ethiopia engages on the CBHI in insurance areas. One of the challenges, it is the way it is moving is that it is a bottom-up and top-down approach where the government is very much engaged. The engagement of the government is manifested by making available subsidy to finance the scheme. And then there are two types of subsidies: general subsidy for the scheme as a whole and for the poor people. It is happening, but as it evolves, I think that the subsidy that is coming to subsidize the scheme is declining. And these are the kind of issues which need to be considered. Always there must be some kind of follow-up, because resource constraint is a serious issue in Ethiopia. I think we have to look into it. And the current issue that we have faced due to COVID, and also the conflict and the budget constraint, you can see that this has also challenged the performance of the community-based insurance. I hope things will be better. The political support will come out. And then I think there is a hope that Ethiopia will be in a better condition to expand and also engage in pooling resources to the zonal and the regional levels. And I think these things will be better. I thank you. That's the only thing I can say now.
Thank you, Shete. Sorry, the questions are coming in quite quickly. And I'm trying to make sure that I also pick ones that haven't been responded to in your broader responses. So there's a question for Professor Kara from Temesgen. Implementation of low-income countries, especially at district level, considered? Is the implementation of low-income countries, especially at district level, considered when we recommend a blended type of PPM?
So I think he said, and he added implementation capacity. So I think that, Temesgen's point is a really important one, that these systems, the endpoint is quite a complex, responsive, carefully crafted system. And clearly moving towards a blended payment system requires, the gradual development of the management and information systems to be able to support that. So I think that's why we've constructed our argument around a pathway. So where can you start? So how do you start to move towards a system that allocates money on a population basis on this kind of equal per capita basis? And that's where some form of resource allocation formula can be the beginning part. And then gradually you allocate, sort of amending that resource allocation formula to deal with differences in need, if that information becomes available, and then supplementing that and complementing it with some either fee for service or some performance-based payment. Or the other thing that some countries have done, particularly in places that have very sparse populations, is that capitation-based payment might be not enough to pay for the fixed costs. So we learned from from Estonia, for example, that there were also lump sum payments made to GPs' practices in really remote areas to cover their fixed costs, and then the per capita allocations were on top of that. So I think that the main point is, yes, you're right, that implementation capacity can be a constraint. And that's why it's important to start early and start simple and think about what are the first stepping stones that we can take to move towards a system that is based on this equal per capita approach to paying for PHC.
Thank you. There's a question which I'll leave open and for whoever wants to respond. It's about referrals. So referral pathways in low and middle income countries are not well developed, and secondary, tertiary facilities may end up having to also provide primary care. Is there a way to align incentives and ensure appropriate financing of primary care in such conditions? So whoever can answer this based on your experience, I think country experience might be very helpful here. Thanks.
Saran, I can kind of agree with the challenge of that, because clearly you can't just deal with provider payment mechanisms at one part of the system. You have to look at what incentives it creates for movement towards higher systems, whether that's appropriate referrals, making sure that the referrals take place in the appropriate numbers and for the right cases, but also bypassing, because if people don't have confidence in the lower levels of the system, they will themselves bypass, and that will actually have the effect of dragging resources back up the system again. And so this notion of getting resources to frontline PHC providers and protecting them also requires that attention to that higher level of the system. I think it's we think of the sorts of countries that have taken on provider payment in that more global way. We think of places like Thailand, which has capitation for primary care, and then a DRG type payment for a case-based payment for district and higher level hospital care. So you need to consider them all together, or there is a risk that you create distortions in the system that just causes money to flow back up instead of being kept at the primary care level.
Thank you, Kara. And I'm sure you would like a break from speaking. So this next question, Ishete, maybe you can tell us a bit more about management boards and I guess your process in overseeing health centers. I have lost the question. Oh, yes. Who are the members? How are they elected from the community? What are their roles?
Yes, before we go into that, if I can say a few words about the referral system, particularly through the community-based health insurance, we have seen very interesting thing. Having the gatekeeping mechanism is not a simple thing to do. For example, what I've observed in Afar during one assessment which we have done, is that many of the people prefer and enroll into CDHI because they have to have access to the hospitals. This is costly, and such a scheme should be bankrupt. And therefore, there must be some kind of gatekeeping mechanism that pushes the beneficiaries to use the health center wherever it is feasible and wherever there is quality of services. It's a very important question. There must be some kind of regulation there. And then coming to the Facility Governance Board, it is really a very interesting question. As the healthcare financing reform was supported politically, I think to have that political support, the Facility Governance Board, it is controversial, but was led by the administrator of that district. And all the sector ministries, including the health sector, are members, and the community representative elected by the community will be a member of the board. And because of this political leadership, because of their busy schedules, that has affected significantly the performance of the Pharmacy Governance Board. And because they have to meet by monthly or quarterly, this is really a serious challenge and may require to revisit again, learning from experiences. And the composition is very much, sector-based, and they're representative from the Women Affairs departments, and also the community representatives. The voice of the community representative will be there. In some places where the Pharmacy Governance Board is working very well, they have got some comments provided in their checklists where they monitor the further fund of the facility. It is really accountability can be initiated through such mechanisms where you can hear, listen and get the voices of the beneficiaries. Thank you.
Thank you. There's a question I thought maybe both Kara and Dr. Sudarshan could answer. The question was about what is included in the $3 in the PHC financing. And I think this came up in both your presentations. So maybe Dr. Sudarshan, can you tell us from your experience?
Yeah. It's a total cost of the human resources. That's a doctor, nurses, the community health workers, their salaries, all the drugs cost, and all their mobility costs, basically. Not only recurring costs, not the infrastructure cost. All included. Yeah.
Shall I respond from the point of view of the Commission? So the PHC expenditure figures that we used were derived from the WHO PHC expenditures figures that are produced as part of the Global Health Expenditure Database. And that takes the healthcare function classifications. It's kind of like a technical NHA type or systems of health account question. So basically it includes spending on general outpatient curative care, outpatient dental care, home-based curative care, and preventive care, and then spending on a share of spending on medical products. We took out of the WHO estimates the share spent on administration. So basically the WHO estimate assigns 80% of the administrative cost of total health expenditure to primary health care. And I suppose we weren't really convinced by the rationale for that. Clearly administration and management is important. So we weren't saying that it wasn't important, but it was really distorting PHC figures actually. So in low income countries, the admin share of total government spending on PHC was really big, like it was over half. And we felt that that was not providing a very clear picture of what was being spent on PHC as a service delivery platform. And nor was the rationale for that 80% of total admin to be assigned to PHC. It wasn't really clear to us. We actually think the better approach is one that's not just based on functions, but also based on levels. And so really countries ought to be able to cross-classify levels against functions so that we can exclude spending on outpatient curative care at the hospital level, which mostly is not PHC. There may be some of that it's PHC, but at the moment it is captured in the spending figures. So in fact, spending at the PHC platform level is probably overestimated by those figures. But that's the recommendation that we make in terms of creating a better classification system that will identify PHC spending at the global level more effectively. Just one more thing I'd say, which is there's a real tension between global standards for reporting. So measuring things the same way everywhere in the world so that people looking at the global level can see what countries are spending, and then having an effective operational definition at the country level, which has an empirical foundation, it's well accepted, and allows countries to see whether they are in fact reaching the achieving the aspirations of increasing spending on PHC. And so I think possibly more important than a single global definition of PHC is having a consistent one at the country level that enables that monitoring of progress to take place.
Thank you. I'm going to, unfortunately, I don't think I've covered all the questions that are here, but Kara, I think there's one more question for you. If you could maybe provide a little bit more description of the blended financing system you talked about.
Sure. So by blended, we really mean just that it's not using a single provider payment mechanism. And so the system isn't just capitation, it's capitation plus other provider payment mechanisms that are designed in a coherent and strategic way to help overcome some of the potential shortcomings of capitation. So we know that every provider payment mechanism has its own risks. So with fee for service, you tend to encourage more services. With salaries, you might, and input-based budgets, you tend to encourage kind of a bit of a lack of flexibility and a lack of innovation. And with capitation, there's also a risk of encouraging undertreatment and underprovision. And so our argument is that systems ideally should be blended to take advantage of the good bits of different provider payment systems to compensate for the bad bits of the different provider payment systems. And that's the argument for blending. But we argue that it should be blended, but that capitation should be the core and other things should be around the edges of it. I hope that helps.
Thank you. And Ashete, there's a question on CBHI in the pastoral communities in the Somali and Afar regions. What are the to your knowledge, the long-run strategies for them to be effective in that setting?
Thank you so much. That's a very excellent question. By chance, I was one of the people who engaged on assessing the performance of CBHI in Somalia and Afar and some pastoralist area of Oromia in the southern region. And we have found out that the parameters should be modified. We should not use the same CBHI implementation parameters which are used in agrarian areas, apply them into the pastoralist area. And for that reason, because of the distance, the vast areas they cover, the mode of life, the CBHI implementation parameters should be modified. That's what's happening. I think they are considering the modification, and that's where we stand now. They are different. They must be different from what's happening in Ethiopia. For both urban and agrarian and pastoralist, the parameters should be different, modified. Thank you.
Thank you, Ishete. I think there were some other questions, and forgive me if they're coming in fast and furious, but I don't think this one was answered. So let me just read it. And I think it's for you, Ishete. In principle, transfer of risk is a very nice approach to demand. It's very nice, will lead to demand and utilization. But in the context of Ethiopia, which party is taking lead to mobilize the pull of the beneficiary and quality service delivery? That makes sense.
I don't understand it. I don't understand what. I wish I understand it.
Sure. Let me read it again. If the person who asked it doesn't mind speaking up, that would even be better. In principle, transfer of risk is very nice approach. I think it's approach to the demand, and the demand will lead to the utilization. But in the context of Ethiopia, which party is taking the lead to mobilize the pull of beneficiary and quality service delivery?
Well, it is not party-based. The selection of the beneficiaries of pool is not party-based. It is a community. And I don't know what the implication of that question, because the community, the pools are identified by the community, and their list will be provided to the district, and their premium will be paid if it's about the poor people for whom the premium should be paid. Otherwise, it is a whole district communities that are engaged and enrolled into the CBHI scheme.
Yes, I'm not 100% sure, and I think it was written quickly, so maybe there are a couple of keywords missing. But I thought it was about who, maybe just within this in the context of Ethiopia, who, I don't know who's, is it Ministry of Health at the regional level or lower that is actually organizing this, but I'm also not sure. Maybe if the person who wrote it can rewrite or directly ask, that would be helpful.
Yes, I will be answering the question after this session also. If they come forward to me, I can provide answer.
I think there was a question, by the way, there have been many requests for the presentations to be shared. So I'm sure they will be. And I see that Kara has put, Kara, do you want to discuss what you've just put in the chat, what link that is?
Sure. So that's a link to the project website on the London School of Hygiene webpage. And those are the links to a set of summary technical briefs that we prepared from the whole report. So they're much more digestible than the great big Lancet report. I'm also just going to stick in the chat the web link for the report itself and for the commentaries that I mentioned earlier.
Thank you. Are there any more questions? I'm not sure if I see any ones that weren't brought up. If I did, please let me know. Okay, I don't see any more questions. So I think and we're almost at time in any case. So perhaps I'll just ask our panelists if there are any last comment you'd like to make before I turn it over to Shishna to close us. That would be great. Thank you so much for your first of all, for your very insightful presentations and also for answering the many questions, some of which were really excellent. But yes, any comments before we wrap up that you'd like to make that maybe were not addressed?
Nothing from me, Sarah, but thank you. I really enjoyed hearing the other presentations, and I'm very excited to hear more about the developments in Ethiopia and how you're beginning to how you're beginning to increase your coverage of community-based health insurance, but also to link that to PHC financing. So thank you.
I don't have anything to add. I thank you. This is a very exciting session. Thank you so much. Over.
Dr. Sudarshan, anything you'd like to close with? You're on mute, sorry.
Yeah, it's fine. I look forward to reading the Professor Kara's the commission report. Hopefully, but very often we shy away talking about leaking vessels, the corruption in the system. I think we should, high time we talk about it and accept it as important resource which needs to be landed. Thank you.
Thank you. I just saw a comment that one question wasn't answered, but questions will also be answered after the, if I missed it, I apologize. Questions will also be answered afterwards. We'll collate what questions are there and what was not responded to. So I'd like to now turn it back to Shishna to close this, and thanks again to our esteemed panelists. Thanks.
Thank you so much, Duran. Great job. This is it's very hard looking at the chat and the various hands and so forth. This was a really excellent panel session. It lived up to my expectations of it, and I really want to appreciate all of the panelists as well as the moderator. I think what is exciting now versus when we used to have these types of panel sessions 20 years ago, is that we have so much more experience, and we have experience in low and middle income countries. And that really was coming to bear. I think the other aspect that came out in all of the presentation is the need to connect and not to treat healthcare financing as a project or a specific intervention in and of itself. So not just do PBF, it has to be really connected. And so that's another takeaway that I also got. And then also the connection between healthcare financing and service delivery, as well as that broader political spectrum. Very key. So even healthcare financing as a whole needs to be connected within overall health system strengthening interventions. And I think that last comment by Dr. Sudarshan was really important. I hope that we have more conversations like this, and I hope that we start to talk more about the gnarly issues, the difficult issues, the politically tricky issues to talk about, the corruption issues. It would be nice to get under the hood there. So I just am very excited about where this conversation has gone and where it will go, hopefully in another iteration. So thank you, and thanks to the Institute for putting this on.
Okay, thank you. I think with that we can close. And do note that the Institute has put a link for the next webinar in the chat also, but I'm sure they will send out an invitation closer to that day. Thanks, everyone.
Thank you. Bye-bye.
Bye.
Bye.
Thank you.